This session on uh, challenging cases in Phako surgery. It's a video symposium, and I welcome my co-instructors, Dr. Shilpa Kodkani. Dr. Sujata couldn't be here because of health issues, and Dr. Ritu Arora will replace and will do her talk. Dr. Suvira Jain, Dr. Mohan Rajan, and Dr. Vavikar, I think they should all be here within some time. So we start off with the first talk for the afternoon. Shilpa is going to talk on circle goes haywire, that is Phako in a case of a complicated rhexis, which is something which we see very often in our practice. With more experience, this is becoming lesser, but then there are cases where the rhexis is not complete or the rhexis goes haywire, and let's learn how to handle this from Shilpa.
Thank you, Nitin. Thank you for inviting me to the course. And so Phako in a runaway rhexis. Well, the most common problem that occurs is in an intuitive cataract. Here, the rhexis is being done under irrigation. The wrongest thing to do, actually, but well, that's what's happening. And you see that the rhexis is being out. So I will with a micro scissor and try.
Don't cry for me, Argentina. Don't cry for me, Argentina. Don't cry for me, Argentina.
Micro scissor go in and on both sides make a link and then complete the rhexis. So now you have two areas where the rhexis is gone out. So the ideal thing, well, here I had already made the incision, but otherwise you can go ahead and change the incision site. But if you're going through the same incision, we make sure that we lower our parameters so that we do not go in the area where the rhexis has gone out, because it can extend from the equator into the posterior capsule. The other thing that should not be done is a horizontal chop, because you're likely to push on the posterior capsule, and that is how, by lowering the parameters, you go ahead and complete the rhexis. While putting in the intraocular lens, another thing that we need to make sure is we should not keep the haptics in the same area, whereas you position it perpendicular to the area of the runaway rhexis. And this is something that is very, very important. Now, this is a very simple case, as you can see, and this is where, in this position here, it starts getting difficult to complete the rhexis. And this is because about 7 to 9 millimeters from the center is where the anterior zonules get attached, and that is where it starts going out and it can cause a problem. So the idea here is to prevent it from going out, you use a centripetal force that is towards the center, and this is what I have done here, and managed to salvage the case by preventing the runaway, by bringing it towards the center. And this is how it has gone out a little, but then the rhexis has been completed. So you can go ahead with your usual parameters in this kind of a case and go ahead with the case in a regular manner. Again, in this case also, because it's not really run out, but it is gone to the periphery, you position the lens away or perpendicular. The haptic should be perpendicular to that area, so that you prevent phimosis and decenturations in the future.
Oh, I wanna know, what's the name of the game?
Prevention better than cure. So what are the things that we learn? Make a nick in the center, aspirate out that liquefied cortex so that you have debulked it and made the convex anterior capsule either concave or on a horizontal plane. Make a small rhexis first so that chances of it going out are less. The more peripheral you go, more chances of it running out. So you make a double rhexis, most often it's always better to make a double rhexis once you have debulked, removed all the liquefied cortex, and complete the rhexis like this. Another take-home message: always stain your capsule in these kind of cases so that you can see better. Well, in this particular case, I found that the second rhexis also was a little small, so I have done a triple rhexis in this case, where I've gone in again at the end of the procedure, made sure that the rhexis is of a good size, and this was also a patient who had a diabetic retinopathy in the other eye. So I made sure that the capsule is big enough so that tomorrow when we need to go in and do any retinal procedures, it will help our VR surgeons. So here you have a nice round rhexis which is about 5.5 millimeters, and this is how it helps us to make sure that we don't have a runaway rhexis. Another poor man's femto rhexis is the zeptorhexis, which is another tool to prevent this kind of runaways in these intumescent cataracts. And you can see here there's a nice round 5.2 mm rhexis. And the other thing about the zeptorhexis is the edges are rolled out, so the chances of it tearing even when you're doing a phaco are very less, because these capsules are otherwise very thin. So this is one additional advantage of doing a zeptorhexis. Now our very own Dr. Mohan Rajan has shown us the punctorhexis, which is low about 30 to 40 power, burst into the center, and then you continue the rhexis like this. So this is another thing. And here I would like to show you all. I do this in all my cases. I go in closed chamber, except for intumescent cataracts, because you need to stain, you need to make your side ports. But otherwise, in all cases other than intumescent cataract, this is something that I follow, and in all my cases, and I have beautiful rhexis because I go in closed chamber. But when we are bending the needle in these cases, we have to make sure that the needle is not 90-degree or even 45-degree bend. It has to be a very, very small bend. I'll try and show it to you all here. A very small bend, maybe just about 10 to 20 degrees. And you can see here, it's hardly any bend. It's only to be able to hold the capsule when you go inside. But otherwise, the reason for this is to be able to go in very easily with your needle, and you have a nice closed chamber, and this is not edited. The rhexis goes like this, perfect, round, no problem. In all cases, I do this, and I have found it to be very, very useful to me. Thank you so much.
Thank you, Dr. Shilpa. That was a real eye opener, especially your last technique of doing a closed chamber. I think we'll have the panel discussion and the questions in the end. I now call upon Dr. Ritu Arora. She'll be talking to us on management of rock hard cataracts. Again, all the speakers here do not require any introduction. They are very well known, so I'm not spending time introducing any of the speakers. Dr. Ritu.
Thank you so much, Dr. Nitin, for having me here. And I'll be talking about the management of rock hard cataracts. These are challenging cases for even very experienced surgeons. And I would say it's a relative term, depending on your experience and confidence. So what may be hard for someone may be a relatively easy surgery for the other. But all these cases, as you can see, they are of different types. And the main challenge in such a case is that there's a lot of compactness and hardness to the nucleus, and there's hardly any epinucleus cushion. So a thorough preoperative examination is important, where you must look at the grade of the cataract, whether it appears leathery or Morgagnian, whether there are any plaques, or is there any phacodonesis or pseudoexfoliation, are there any comorbidities. And a good look at the pupil dilation, because that is going to help you to plan your surgery, and the AC depth. Of course, a B scan, for the posterior segment evaluation, and such cases where, even your optical biometers will fail. So a contact or immersion biometry is important. Taking a history of tamsulosin again will help you to plan your surgery. And if you have access to a specular microscopy, that's good for knowing the endothelium health. Rexus is the nemesis, and my previous speaker has already very beautifully illustrated how one should do. As she said, always stay in these cases. Because they have weak zonules, they could have plaques, and you must have a good sized rexus, because these hard cataracts are going to require a lot of chopping. Using a good cohesive viscoelastic, using the soft shell technique is good. And I would say keep your ego aside whenever you're doing such cases, no matter whether it is your 1,000, 2,000, 20,000. Ego must be kept aside. If you feel more comfortable with a block, please go ahead or shift to a subtenous block midway during surgery. More than anything, you be calm so your patient also remains calm. So I'll just show you, actually, I may just, skip some of these Rexus videos because they've already been shown so well. But I also prefer to go in with the needle, although, one should be well versed with Rexus faucets and needle as a little, another case which is actually quite an intumescent cataract, but it also has a very nuclear, hard nucleus lurking behind. And again, as soon as you blink, you can see Rexus when you're doing your chopping. So again, this is again another case which has a very fibrotic plaque, and the important part is to go around the plaque, because you cannot sometimes if the plaque is so dense, you may have to. So if you have access to flax or femto, of course, that's good. You have a double advantage. You can do your Rexus and you can soften the nucleus also. Or a Zepto, again, is a very convenient way of doing it. And coming to the Phako maneuvers, it's good to do a temporal if you're comfortable with it, or if you feel you're a beginner and you may want to convert, then a superior incision would be better. Hydrodissection should be extremely gentle, multi-quadrant, and very small aliquots, because you hardly have any epinucleus. And a liberal use of OVD, as I already mentioned. You must do more of Phako chop techniques rather than go for sculpting. Minimize the Phako energy, use the burst or hyperpulse, and use your torsional or transverse ultrasound. A high vacuum, high flow rate surgery is always better. And my loop is another thing. I don't have a personal experience. I tried it out, but I was not comfortable with it. And at the same time, be ready to bail out. Be prepared for all eventualities, a CTR, pupil expander, keep your anterior vitrectomy on standby. Don't be hesitant to convert, and always be watchful for the ominous signs like the pupillary snap sign, or the sudden deepening of the anterior chamber, or tilting of the nucleus, or suddenly you see an area where the glow is more. So there's always an insight as a surgeon that you have that something is not right. And at that point, you must always stop, reconsider, or even call out for help. So I'll just show one small video because I really didn't have time when Dr. Nitin told me. I just took out one of these videos. So as you can see, it's a dense cataract with very poor glow. You must stain your capsules. Do your Rexus, as I said, a good sized Rexus is required. And after you've done a gentle hydro, of course, there are many ways to skin the cat. And I prefer to do a chop technique, but at the same time, my go-to technique mostly is the flower petal technique. Many other techniques have been described, like the terminal chop. I also like Dr. Pradeep Mohanta's submarine chop. And here you can see I'm making several peripheral chops, trying to use the natural lines in the lens to separate the leathery cataract. And don't be over exuberant. It's okay to make small cuts and use multi-level chopping. Try to go deeper and gradually tease the leathery fibers apart. In fact, contrary to most people, I like to keep my posterior plate intact rather than have a complete cut, because I feel that protects your flaccid posterior capsule. And the central part of your nucleus, once you've done the multiple chops, you can have almost a ball coming out at times, which can be, emulsified. And so here also repeated injections of viscoelastic are important. And here you can see how I'm teasing it into the center, amputating the periphery. So you're actually cutting off, you can say, the petals. So one by one, you do the chop, bring it a little bit into the center, and then use your chopper to amputate the central part. So that way all the periphery gets cleared up, and in the end you have a thin posterior plate kind of thing which can be then emulsified. I'll just fast forward over here. So you must be patient and take, the pieces are small, try to make as many small pieces as possible. And keep filling the anterior chamber with viscoelastic as and when required, so that you keep protecting your endothelium. Okay, it's almost done. And be slow in the end. The last few pieces, you can reduce your parameters and look for any lurking pieces here and there. So you've got a good surgery, a nice clean capsule, and there was actually no need for doing an IA because there was no cortical matter. And you can see the wound is also clear. There's no wound burn in such a case. Always go behind, remove the excess visco, and I'm sure you'll have a good result in the end. Thank you so much.
A wonderful, wonderful talk. Nice videos, Ritu. Very beautifully done. I think the message is very loud and clear that hard cataracts, you need to be a little slow. Don't have any ego. Use good viscoelastics, good chopping techniques, and fantastic. Really good talk. Over to Dr. Nitin, and he's going to talk to us on Phako in small pupils.
At the outset, I would like to thank the scientific committee for having this course. It's nice to see here all of you all post-lunch. So my topic would be how to manage small pupils. So we all know that a good pupillary dilatation is something which is very important for a phacoemulsification. However, there are times when we are not able to achieve this. आगे नहीं जा रहा है. Okay, so there are various methods by which we can, there's a very busy slide, by which we can achieve intraoperative pupillary dilatation. Some are mechanical, some are non-mechanical. The non-mechanical would include a viscodilatation, a dilatation with intracameral mydriatic agents, a stretching the pupil, that is a stretch pupilloplasty, sphincterotomies. The mechanical ones would be iris hooks, rings, Malugan ring, Behex ring, and Gaither ring. So let's individually deal. Now this was a case of a Phako in a pace. Important to know how to manage when the pupil comes down during surgery, because that may be a time when it is difficult to introduce rings. So this is a small pupil case being done without any hooks or rings. So most important thing here is to make the rhexis margin as close to the pupillary border as possible, and do all your chops, a vertical chop, uh, and definitely not a tangential or a horizontal chop, because you wouldn't know where the rhexis is. Like in cricket, it is said every batsman should know where his off stump is. It's very important to know all through the surgery where your rhexis margin is, so that you don't go beyond the rhexis margin, especially in these cases. There are chances of some amount of the fragments coming up into the chamber, so you may not be able to do the whole thing in the back. So therefore, constant refilling the chamber with a viscoelastic is very important. So the next video which I would like to show is a Phako in a patient with a small pupil, where we use intracameral mydriatics. Now, intracameral mydriatics could be either epinephrine if the patient is fit for it, so your anesthetist has to certify the patient doesn't have a cardiac problem, or you can use the Phenocaine Plus. I don't have any financial interest. There is the Tropicacil Ultra, which is basically a combination of phenylephrine with Tropicacil and proparacaine. So you see, you can achieve a good dilatation by intracameral mydriatics, and then the whole procedure is as smooth as anything else. The Varion capsular rhexis guide is for a 5.5 millimeters. So you've seen that our pupil has gone up to 5.5 millimeters, a little beyond 5.5, and therefore it's easy to complete this case. The remaining steps are quite similar to any other routine phacoemulsification, but one should know that this is something which you should use initially to see if you can achieve pupillary dilatation, and if it is possible, then you don't need to have the rings and the hooks put in, and make the case more simple. Now this is a case where we are doing only a viscodilatation because mydriatics have not worked, intracameral mydriatics have not worked. Now when we do a viscodilatation, it's very important not to fill the whole chamber with the viscoelastic. Moment you fill the whole chamber and press the iris down, you will not get a good dilatation. So you initially start off by injecting a little bit of viscoelastic, so you create a plane, and now you go to the sphincter edge and very gently, all 360 degrees, start injecting the viscoelastic in a circumferential manner, and you can see there how easily the pupil dilates. And you can believe me, there are cases here where we can do with a viscodilatation, get a pupil of at least a 5 to 5.5 millimeters. And if it is not a hard cataract, one can go ahead with phaco surgery without again the use of hooks or rings, therefore making the surgery more simpler and spending lesser time on the procedure. Now this is a case where we do a stretch pupilloplasty. So again here, after having injected viscoelastic, what we do is we use 2 Y hooks, one from each of the side ports, and we are stretching the pupil in the opposite direction. Now these stretches usually should be obviously in the opposite directions, and usually they don't cause a big amount of sphincter tear. There are small sphincter tears which you can notice at the end of the surgery, but you still achieve a good circular pupil at the end of the surgery in spite of doing a small amount of sphincterectomy with the stretching. Again, now having injected viscoelastic after the stretching, one can go ahead with a good pupillary size. Iris hooks are something which can come to your as a savior in cases where you cannot achieve a pupillary dilatation with any other procedures. I normally prefer to use 5 iris hooks, one below, just close to the incision side, below the incision side, above the incision side. And once you get a large pupil like this, which with 5 hooks, it would be more of an hexagonal pupil, one can go ahead and do a routine phaco surgery in these cases. Again, while inserting the iris hook, your incision needs to be at the limbus and not at the cornea, because if your incision for the iris hooks is at the cornea, you will tend to pull the whole cornea up when you tighten the hooks. So following the surgery, the iris hooks can be removed. They can be either removed from the main incision or they can be removed from the incision in which it was made. Malyugin ring is another device which is available, and this works very well. So again, in these rigid pupils, we see that a Malyugin ring which comes with the injector system, we inject a viscoelastic in the chamber, This comes with the injector system where you withdraw the whole Malugian ring into the injector, and this can go in through an incision as small as a 2.4 incision. Now, a bimanual technique is very important. You need the other hand, other instrument to be in the chamber to guide the Malugian ring. This is like basically like a safety pin. The scrolls are like a safety pin. So the leading scroll, you try and first achieve a catch of the sphincter. The side scrolls can then be placed in the right position. One needs to create space between the lens and the iris here with the viscoelastic. Don't fully fill the chamber with the visco. Now, the advantage of the Malugian ring here is that you can adjust the Malugian ring in order to centralize the pupil. So as you can see in this case, we have started the rhexis. And somewhere in the middle of the rhexis, when you feel that your rhexis is going, the pupil has gone off center, and if you're centering the rhexis on the pupil, you can use a hook to try and re-centralize the pupil by adjusting the position of the Malugian ring. The remaining procedure in this case also remains the same. A breather pupillary expander is another device which is basically nothing but a silicon tire, which is a very elegant way. It's a silicon tire which goes in through a 2.2 millimeter incision. It's a circular tire, so here you get a nice and circular pupil. You just need a second instrument to hook the pupillary margin within the tire, and now you've got a nice circular pupil. I'll just take a minute more. And following Phako emulsification, removal of this is very simple. So you just disengage the tire and pull it out with the forceps. Again, no sphincteric tears because you're not stretching the sphincter at all here. And the last case here is a device which we all are aware of, our own Dr. Suven Bhattacharji's BHEX ring. This is a very slim device. There is a learning curve, especially while using the BHEX ring, because we need to engage alternate scrolls, and we get a nice 5 to 5.5 millimeters hexagonal pupil. Again, in cases of a very rigid pupil, it may not be possible to use this ring, and iris hooks would be the savior in those cases. So there, as you can see, you got a nice hexagonal pupil. And removal of these rings following surgery is very simple. You just need to disengage the scrolls, and this can be pulled out through a 2.2 millimeter incision. The latest ring can be even inserted through your side port and can be removed through the side port. So there are various methods. So basically, it's important to stress, the take-home message is that it is horses for the courses. There is not one particular method by which you tackle small pupils. There are various methods, and we should have all these methods within our armamentarium. Thank you. Thank you for your kind attention.
Lovely talk, Nitin. You have covered everything, starting from the pupil stretching and the iris hooks, the Malugian greater, and BX ring as well. So I think it's a very good coverage. I think the important message is small pupil, don't take it lightly, because all the complications are related to small pupil. Because you don't see well, you don't operate well, and all the complications can occur. So right in the beginning of the surgery itself, you decide, I want to dilate this pupil mechanically and do it. Because in between the surgery, is very difficult to put an iris hook or a Malugian ring or a BX ring for the matter. We'll go on to the next talk by none other than Dr. Suvira Jain from Mumbai, and she's going to talk to us on hanging on a flimsy rope, that is Phako in zonal dehiscence and subluxated cataract.
It's not playing there. Good afternoon, ladies and gentlemen. I'm here to talk to you today about the management of an intraoperative zonular dialysis. Let's start with the first case.
The biggest unpredictability of intraoperative zonular dialysis is that you don't know the extent of the dialysis ever. Now, at the end of Phako, you can see that there's an inferior prolapsing of the bag, and while trying to put in visco, the zonular dialysis actually gets worse, and there is clearly the vitreous that's pushing the bag downwards. So, with a hand-on-hand maneuver from the opposite direction, a CTR is inserted into the capsular bag, and look how the trailing eyelid is hooked onto with the Sinskey hook, turned around, brought in its correct position, and then released with the help of a repositor. You can clearly see with the iris sweep that we've got a peaking of the pupil, which in this case was managed with a limited scissors vitrectomy, giving you a round pupil. In this second case, while performing a removal of the epinucleus with the coaxial IA, the surgeon notices folds under it. So the first thing you do to not make things get worse is do a viscofluid exchange. After the viscofluid exchange, note how the CTR, which is generally a 10 to 12 millimeter one, is introduced from the area away from the subluxation towards the subluxation. And then again, it is slipped in, turned around, and then released with the help of a repositor when it is in its correct position. Moving to the third case. Here's a patient who, while performing a coaxial IA, the surgeon accidentally yanks onto the equator, creating almost a 5 clock hour of a zonular dialysis. So the same steps, viscofluid exchange and a linear circumferential delivery of the CTR into the bag. Now, how do you figure out where do you release the trailing eyelid? It is very important to turn the CTR in such a manner that the open area of the loop is not in the area of the zonular weakness. Now, here's a patient who we get so comfortable when we put in the lenses, but here in this case, at the end of putting in the lens, such a harsh tap on the posterior capsule has resulted in a zonular dialysis of at least 3 to 4 clock hours. Now, in this particular case, the surgeon got away by just literally rotating the IOL such that the haptic is abut it, and it centered well, so it was left alone. Now here, again, towards the end of nuclear emulsification, everything looks okay, but as soon as the instruments are brought out, there was no way that the surgeon would have known that there is a zonular dialysis here. So the instruments are out, and we come back, put in viscoelastic, and put in a CTR. The angle should be such that it's directed towards the bag, not too shallow that it gets into the angle, and not too deep that it endangers the bag even further. Now, when we are dealing with the direct chop technique in hard cataracts, our intraoperative maneuverability is often a lot more. Here you can see the surgeon is pulling on the fragment and has created a zonular dialysis. This is the fishtail technique of introducing a CTR, which I sometimes use, wherein the same standard PMMA CTR is flexed, held flexed, and the loop is pushed under the capsule into the bag, after which each of the eyelets are then introduced. The biggest advantage of this is that you don't make the zonular dialysis worse. The disadvantage is that you can use it only in cases with an inferior zonular dialysis. I think you put in a CTR as early as you notice a zonular dialysis, because it straight away opens out, gives you the equatorial stability of the bag, and allows for safe phacoemulsification almost each and every time. Now, this is a case wherein, but it's not always this smooth, is it? Here, there's a significant zonular dialysis because of excessive intraocular manipulation and the expansile forces during a Phako. But look what happens sometimes. When the surgeon is trying to put in the CTR, can you see it's getting stuck? It's not going, and it's actually just pushing the nucleus so that it's starting to tip further downwards. So after holding it up with an iris hook, the capsular bag, the surgeon is now able to go ahead and complete the nuclear emulsification. So you have to make sure that even putting in the lens, putting in the CTR, it goes in very comfortably. Ideally here, I guess, perhaps a 3-piece lens would have been a better option. However, here I didn't have one, put in a monofocal lens, and it went well. It was well centered, and it stayed stable. Now here's the cases with a small pupil and a Mogiagnian hard cataract. So the pupil is first dilated using a Malyugin ring, and typically you see this intumescent fluid coming out. But look, when I try to extend the rexes here, you can actually see the whole bag is getting pulled here, making you think that obviously there is some kind of a zonular instability. Now, at this point, I think putting in a CTR with half the rexes done is likely to make the rexes go haywire. So I've managed to complete the rexes. Then the CTR is introduced into the eye. You get your equatorial stability of the capsular bag. And therefore, because it's going to take quite a bit of energy and expansile forces to even perform a direct chop in this case. So once you've redistributed the forces such that the bag is now stable and strong, then I've not shown it here. You just complete with direct Phako chop using the right maneuvers, limited mobility, and see how you go. In this case, look, when the surgeon is attempting to do a horizontal chop, he actually, instead of hooking out the nucleus out of the bag, has hooked out the entire bag. Now, in this case, the surgeon has chosen not to put in a CTR just then, completes the nucleus management, as you can see. So there definitely was a significant zonular dialysis. Perhaps it might have been a better choice to put in a CTR then and there and continue, but it was not done. And obviously at the end of the nucleus management, you can see that strand of vitreous coming here. So what do? The same steps. You do a viscofluid exchange, then put in a CTR, try and get this, regain your equatorial stability of the capsular bag, which is done. After the introduction of the CTR, then with the coaxial, the cortex is removed. I've just shown this in fast forward. And once the cortex is out, the surgeon actually puts in the lens. That seems to go well too. But at the end of, whilst performing the cortex wash, there was that strand, remember, it's still there. So you got to do something about that strand. You've got a stable bag now, but you've got disturbed vitreous. So with the CTR in place, IOL in place, with the after staining with triamcinolone, a coaxial vitrectomy is performed in this case, which gives you now an anterior chamber at the end, free of vitreous, a stable centered bag, and a stable centered IOL. Now in this case, it's not my case, but it's an important step that I wanted to show you. This patient has got a zonular dialysis intraoperatively in this grade 2 cataract. The point to remember is, after putting in a CTR, if you can see the edge of a CTR, it actually means that the bag is not exactly centered. Despite the CTR in there, it's not centered. So you need something else to strengthen it, and here a capsule tension segment was used. Now, a capsule tension segment sometimes can also be used intraoperatively without even removing the lens. And obviously, you can't fixate it with the nucleus, such a big nucleus in its place. But you can, in order to attain an intraoperative stability of your bag, hook it, pull out the hook, because it's about 180 degrees of pulling the bag out, which helps you then complete the nuclear emulsification. And then you can end up fixating it to give you a long-term stability. There's not enough time, so just to touch upon, when you have a zonular dialysis that is this significantly large, more than 4 clock hours, you then perform a capsule tension segment fixation. And that should be done. I tend to do it after putting an IOL in the bag, because one, the IOL protects the posterior capsule, and from the sides of fixation, two of the needles hooked through the eyelet of the capsule tension segment are pulled out. And with the IOL in the bag, which is not shown in this video, you pull out, titrate how much you pull it out, and then you tighten the knot to give you a well-centered bag. I guess these are the cases I wanted to share with you. Thank you very much.
Thank you, Savira. That was really lovely. I now call upon Dr. Mohan Rajan, who is going to talk to us about PC rent during Phako and how to manage it.
Good afternoon, friends, and let me thank Nitin for this wonderful opportunity. And I'm going to talk to you on a very important topic. There is a hole in the bucket, the PC rent during Phako. How do you manage this? These are my financial interests. So how many of you have not had PCR at all? I want to know before I start the talk. Anybody who has not had PCR? Okay, there are only two things if you have not had PCR. One, you are telling lies, Second, you are not doing cataract surgery. Okay, that day in Amritsar I was presenting, when Sardaji put up his hand and said, I have not had PCR in my life. Then we found out he was an ENT surgeon. He has come because his wife was an ophthalmologist there. So that's the only way you can have. So the thing is, anticipate PCR in these conditions. When you have a traumatic cataract, when you have a posterior polar, hard brown cataract, pseudo exfoliation, and post vitrectomized eyes. Nowadays, we have patients who are coming with repeated injections of Lucentis or Avastin. You need to be a little careful about these patients. You need to have a plan for these patients. So, if you understand this slide, okay, this animation about PCR, then I can stop talking here, because this is the most important thing. When you have a PCR, if you have a coaxial irrigation aspiration, coaxial means the irrigation and aspiration are in the same port. What will happen? The vitreous is like a tsunami, okay? More and more vitreous will start coming into the anterior chamber, it will hydrate the vitreous, and what is a small PC tear will become a very huge PC tear. But when you have a PCR, if you stabilize that globe, which I'm going to tell you how to do it, and then go in for a bimanual. Bimanual means the irrigation and aspiration are separated. The irrigation is on a left, the aspiration is whatever it is, or the cutter. So the irrigation and aspiration are separated. The irrigation actually tamponades the break, prevents the hydration of vitreous. And whatever vitreous is there in the anterior chamber, you can just, pupillary area, you can just cut it off. So this is what you should not do. But many of us do. You can see here, what is the most important thing is to don't pull out. If you pull out, what will happen is the PC tear becomes a huge, when you say, you become jittery because you may be operating on a VIP patient or a doctor. Then you go bimanual. And what happens to the nucleus which has gone in? Okay, depending on whatever karma you have done, okay, the nucleus will come up. Okay, depends on the karma, that is very important. So this is a nucleus by luck it came up. But more importantly, I think the message is very clear that you need to be bimanual. Go bimanual and remove the vitreous first and then remove the cortex. So I'm just going to show you, this is a patient who had a PCR, you can see that PC tear, and it's like a posterior capsular X is there, and this is one of the former union ministers, and as you know, these politicians commit a lot of sins and then come to you, and then this PCR occurred, and he had a very brown cataract. Immediately what I did was I injected Viscoat. I don't have any financial interest. The Alcon guys are not paying a single paisa to me. So the Viscoat, what happens? It goes and plugs the PC tear, okay? And then sit back and relax, and then shift to the right side port, and then go ahead and remove the cortex, remove if the vitreous is there. At that time, about 15-20 years back, the tricot was not available. So the message is very clear that you need to put Viscoat, come out of the eyes gently, reduce the bottle light, and then don't come out without filling the viscoelastic. This is very important. If it's a small PC tear, you can convert that into a posterior capsular excess. Okay? Because the posterior capsular excess has got a much better strength than your PC tear. If you try to put a lens in the bag in the presence of a PC tear, that PC tear will extend and the whole lens will go into the vitreous cavity. If not on the table, the next day it will go. So I think it's important that you do a small posterior capsular excess, very important again. And you can see this is a patient who had a PPC. You can see the plaque on the posterior capsule. As I was trying to remove the epinucleus, there is a sudden deepening of the posterior. You see the PC tear has occurred. Immediately I put Viscoat and then immediately put tricot. Why tricot? Because tricot delineates the vitreous. It's important to have a tricot there, preservative-free tricot is available for all of us. And then I'm removing the vitreous first and then removing the cortex. And if at all there is some vitreous, I just remove it off then. But don't remove the cortex in the presence of the vitreous. Why? Because you don't want to produce any traction on the vitreous base. So every time you do that, you produce traction on the vitreous base, and post-operatively these patients can develop retinal attachment, retinal tears in the periphery as well. So I'm putting a lens, a multi-piece lens. So you have all these lenses in your armamentarium in your OT. This is a patient who had a posterior polar cataract, mature cataract, okay? If you have a mature cataract, you do not know whether it's a posterior polar cataract because But look at the fellow eye. If the fellow eye has got some lens in the sulcus or an ACIOL iris claw lens, then it's always so. Obviously, this patient had a posterior polar cataract. You can see here. Very typically, what you see it's not a posterior capsule tear. It's like a posterior capsule dehiscence, which is very, very typical of this posterior polar cataract. This is a dehiscence. This is a congenital dehiscence. It's like two pillars on the posterior capsule. And immediately I put viscode there, and then I did femto for this patient, catalyst, and I went in and did a see, as long as the anterior vitreous face is intact. So I was a little more overzealous, and you can see and tried to remove that cortex, which is actually stupid of me to have done it. You can see that once I've done it, I ruptured the anterior hyaloid and the vitreous started coming out. You can see that there's a hole in the anterior hyaloid, and obviously we need to do a vitrectomy. No using sponges, no using scissors, only automated vitrector. Okay, that is very important again. So have a bimanual, that is irrigation, and you can have an anterior chamber maintainer, and then go ahead and you can see how I'm removing the vitreous, and subsequently I put a lens in the sulcus and capturing it in the back. So the another patient you can see here again a posterior capsule, posterior polar cataract, and so far so good. It's going on very well. As I'm removing the what you call the epinucleus pate, you can see that he's actually an ophthalmologist from Tamil Nadu, and I was operating young fellow. So I told him about the consulted him pre-operative. You can see there is a huge PC tear. It's not a PC tear, again a dehiscence. I injected viscode, then immediately shifted bimanual. Then once I found out that vitreous is there, I did use the cutter, and then went ahead and removed the vitreous. Use a high cutting rate. All the machines are now equipped with high cutting rate machines. 23 gauge cutters are available. 3000 cutting rate. Cut and move forward, don't cut and pull. So if you want to remove the vitreous, which is very important, use tricot. Even God cannot see the vitreous in the anterior chamber without tricot. So you need to make sure that you use tricot there and remove the vitreous, and then remove the cortex there. You can see that the capsulorhexis is intact, but you can see the two pillars on the posterior capsule, very typical of a dehiscence in a posterior polar cataract. Again, putting a lens, you can see here, put the lens in the sulcus, but don't leave it in the sulcus. Again, very important. The haptic is in the sulcus. This is a 3-piece lens, MA60 lens, and the optic goes into the bag, into the capsulorhexis margin. This is called the optic capture or locking this lens. If you lock this lens will not move a micron and for several years together. Otherwise, if you put it in the sulcus over a period of time, it can decenter, or it can also produce what is called UGH syndrome. And you can see this is a locking of the lens. The ovalization of the anterior capsule is something which is very, very important again. Again, another patient who had a posterior polar cataract. I'll just take another 1 minute, Nathan. And you can see here, I'm doing a bimanual irrigation aspiration and going ahead. And in this case, I was able to, this is actually a doctor, and again, general medical doctor. And you can see here, I'm keeping that anterior hyaloid intact. How? Because repeatedly I put viscode. When you put viscode and use an irrigation aspiration, make sure that your aspiration flow rate is not very high. If you have very high, because the viscode can get aspirated, now and then you have to put viscode. You can see here, I was able to put the lens in the sulcus and then capture it in the back. So again, pars plana, anterior vitrectomy or pars plana, all these are things to go. These are take a message, small PCR, convert to PCC. Do not pull out, inject viscode, use tricot, preservative free, bimanual, automated, anterior vitrectomy, limbal or pars plana, whatever you're comfortable. Remove the vitreous first and then remove the cortex and epinucleus. Appropriate IOL depending on whatever you feel. Suture the wounds, because when you have vitreous loss, PCR, the incidence of endophthalmitis goes up by about 4 to 5 times. I always suture my wounds because there can be micro leaks. Thank you very much again. Thank you very much, Nitin.
Thank you, Mohan. As usual, it was a rocking videos. I now call upon Dr. Chandrasekhar Vavikar, who is going to talk about managing complications in flax.
Thank you, Nitin. Very nice presentations. And I'm going to start with Robogan Roj, that is complications of flax. So it's a video throughout, but I'll be giving the comment. Now let us look at how a normal case of flax is done. It is very essential to have central docking, and that takes care of most of our problems. And then you adjust everything on the dial and also on the OCT. Nucleotomy, capsulorhexis, nucleotomy followed by incisions. In most of the cases, when you have central docking, the incision opens very easily. It just takes 1 to 2 seconds, and after that, capsule is 100% cut in most of the times, and you have to just separate it with the help of visco. Similarly, the nucleus pieces, they are very well dissected. We just need to mechanically separate them. The amount of force required for separating is much less than what you require for chopping. Now let us look at the complications one by one. Most of the times when the patient is anxious, okay, or you have a small palpable fissure, you have eccentric docking. Now, eccentric docking, you can have a problem with placement of the incision, placement of the CC. You can see that the nucleus is appearing tilted. It is not tilted, it is because of eccentric docking. And capsulotomy has to be placed very well, but we are getting lot of time to adjust, and lot of parameters are there. Second, next complication which used to get previously, now with the introduction of PI, it is not there, and that is air bubble during docking. This we find more commonly with RK patient with very flat corneas, and many times we have to redock. Then sometimes there can be corneal folds. Again, this is an unexplained thing. The software PI is very good, but you do get these folds, and because of air bubble or whatever complications we have explained before, we have to complete the capsulorhexis with the help of a forceps. So wherever the folds where you can see that there is a tag attachment attached, and it has to be separated. Now there is one interesting surgery we'll like to show, and it was a 72-year-old lady. I started doing flax, normal case, everything going smoothly, incisions opening properly. Hydrodissection, I don't do hydrodelineation, and after injecting visco, I started doing Phako. Phako also was very, smooth, no doubt of any problem. You can see even in the grade 3-4 cataract, separation of the pieces is very, very easy. And then cortical wash and then implant. So basically what went wrong? It appears that everything was very, very smooth, but however the patient had a very, very cloudy cornea, and it refused to get clear. And that is where we decided to look at the video again. So let's rewind. There were enough telltale signs, but we were just blind to them. You can see that I am just dissecting a membrane out here. This is sign number 1. Now, if you see the air bubble on the extreme this side, our left-hand side, you can see that the configuration of the air bubble is not correct. So, as if there is some membrane in between. Again, same sign, okay. So, basically what I had done is that I was doing all the maneuvers above the dismissed membrane. And you can see that the membrane is there, and now I have taken the rhexis, and now you can see I am taking another membrane, okay. But it was so crystal clear that I did not have any doubt. Of course, patient had to go ahead with dissect, and that is when we started observing our surgery videos more carefully for whether there are any signs. And you can see, even in a case where we did not have descemet detachment, there are signs. Luckily, these complications are very few. You can see one air bubble over here, that arrow. Similarly, there is one more air bubble over here. We call it immobile air bubble sign. It's because if you see, those two air bubbles are constantly present, this one and the second one, throughout the surgery. So you can do all the maneuvers, it will be present. Basically, that is the air bubble in the pre-descements area. So I will take two separate side ports. And ensuring that that area does not get touched at all, or even the fluid does not go there. I completed the Phako gradually, and even during IA and lens implantation, those two air bubbles are there. Essentially, there was a problem with the layer separation and the energy size, and once we sorted it out, this problem disappeared. Of course, it's not happening too often, but it did happen, 3-4 cases. Now you can see that I am overhydrating in an attempt that the air bubble becomes smaller. I am even hyperinflating the entry chamber, but the two air bubbles still remain. And that is where we started to decided to have a careful look at the literature. So it is a real-time OCT to understand what is the incidence of descemet membrane detachment during cataract surgery. And to my surprise, the incidence of DMD is almost 94%. That means in every patient we are getting. And out of that, 80% of the time, anterior as well as posterior, both the lips are getting detached. Only very few cases, it's either upper or lower, everything is getting detached. Now, the last moral of the story is that it is always there, but we have to be careful while introducing the instruments and look for signs whether anything like this is happening. And if we see immobile, of course, it does not appear in a normal cataract, but at least in flags, we can see that sign and take corrective action. Now, the last complication is not per se a complication of Lensex, but it does trouble us sometimes. That is the registration failure. That is the virion does not register. There are many reasons: arcus senilis, mature cataract, improper illumination, etc. And once we do this, we get more registration. Even then, the incidence of registration failure is around 5%. This is the only thing which is kind of bothering. Thank you.
Thank you, Dr. Vavikar. Since we have 2 minutes more, I think if there are any questions from the audience, the panel can take it now. So since there are no questions, I think we'll bring this session to an end. Thank you for having attended, and I thank all my faculty members, Dr. Ritu Arora, Dr. Mohan Rajan, Dr. Suvira, Dr. Shilpa, and Dr. Vavikar. Thank you.